That's why the stool softeners, for at least 6 to 8 weeks afterwards. But the most important thing is that he is going to come out of his surgery and he's going to have continuous bladder irrigation in place. He's going to have a catheter going up his penis into his bladder that really does look like a garden hose, folks. Yeah, but he won't know it because we put it in while you were under, so you didn't notice it at all, okay? So anyway, it's going to look, it's pretty big. It's a 3-way irrigation system. Two of the ways, there's 3 tubes. 2 tubes get hooked up to big, huge bags of about 2,000 to 3,000 cc's apiece, and the third one drains the urine and the whatever drainage we put into him out. Anyone who's got continuous bladder irrigation, and if that person is your patient, it's really important that you measure I's and O's very, very carefully. Okay? And the word is continuous bladder irrigation. In other words, it has to flow continuously. You cannot clamp it. You cannot, I cannot tell you how many nurses I know who would go in and just clamp the silly thing. Well, I had a student nurse who was taking care of a patient with continuous bladder irrigation. She was a jewel and a gem. She went in, took care of it. It was wonderful. It was fantastic. And it's all done. All right? She came out, took care of another patient, went back in. It was clamped. Okay? This happened a couple or 3 times. So we went to the nurse who was the patient's primary nurse and said, this thing keeps getting clamped. You got any idea? She said, yeah, I clamped it. And we said, why? I didn't have the time to go in and check him. So what she figured was she would go in, when she did check him, she'd unclamp it, let it flow, and then after what, clamp it and leave. No. The word is continuous bladder irrigation. It's very important for you to continuously irrigate, and it's also very important for you to do I's and O's and strict I's and O's. Remember, your output must be more than your input with CBI, right? Because he's also producing urine. So that output must be more than input with continuous bladder irrigation. If the output is less or equal to, you have a problem. You have a big problem because that means he's not producing urine. So that means we need to check into this a little bit more. Okay, couple of questions. Number one, I was stopped by a young lady who works for hospice, apparently. And the question that she had was, I have a hospice patient, and she's now in the ICU. What do we do for her? Now, you all know that with hospice, it's an end-of-life issue. And essentially what it means is that you make the person as comfortable as you can. You do not deny the person anything that could make him or her comfortable. So her question was, do we start an IV? Do we give fluids? Well, that really is dependent upon several things. Number one, I would say yes. First of all, I would say yes. Start an IV. Give the fluids. We're not asking you to do anything heroic. It's not a ventilator, okay? It's certainly not a respirator. It's not a big deal. Starting an IV and giving fluids is comfort measure. Okay, it's a comfort measure, unless the person has no veins. And you know what that means. If the person has no veins, you're not going to put in a central line. That would not be a basic comfort measure. And that's something that the doctor would not want to do. This is a hospice end-of-life issue. But if it's, possible to find a vein and start an IV and just give basic fluids, yeah, I'd say yes. The other thing I want to say is that this sort of issue, end-of-life hospice patient, that really depends upon the family, the living will, the doctor. That's a interdisciplinary decision to make. It's not something that the nurse makes. It's not a decision that the nurse makes, okay? One more time, I would say, yeah, IV, got nice veins, started, go ahead and give basic fluids. But no veins. You're not going to put a central line in. You're not going to put an external jugular vein, line in. You're not going to do anything heroic. That's heroic. A basic IV is not heroic measure. All right? Pretty clear? Okay. I was also stopped in the bathroom and asked if I would please go over. Hey, catch me wherever you can. I was asked if I could go over, please, the EKG and tell the difference and maybe help you all understand a little bit more and understand the difference between AFib and VFib. It's really very easy. But before you get to AFib and VFib, you must know the basic EKG, the basic QRS complex, how the heart functions. Okay, if you look at what I just drew up here, this is your basic EKG strip, all right? The first bump, where my finger is, can you see that? That first bump, what's that? That's your P wave, correct? That's your P wave. All right? Do you see that? Okay. That P wave represents atrial, the what? The SA node firing. It represents atrial, what? Depolarization. Exactly. Okay, so let's use the words, the correct words. That P wave represents atrial depolarization. Now, what happens is the SA node fires, then the atria contract, and then your little electrical activity moves down the heart to the AV node through the bundle of his, to the Purkinje fibers, and this thing here, which is the QRS, that's your QRS complex. That represents ventricular depolarization. All right? Ventricular depolarization. This thing here, which is your T wave, represents ventricular repolarization. In other words, the depolarization is when the ventricles contract. That's activity. To repolarize means to get your energy back again. All right? P wave, atrial, QRS, ventricle, T wave, that's where the ventricles regain their activity. Okay? Where does the atria regain their activity? Right here in the QRS complex. But it's buried in the QRS complex. The QRS complex is so strong that it hides the little activity that shows where the atria are repolarizing. Okay? So you know that the P wave is atria, QRS is ventricle. Yes? Good. Now, let's move on, and we'll talk about atrial fib versus ventricular fibrillation. If it's atrial fibrillation, what does that mean? It means that the atria are fibrillating. And fibrillation means to contract and, it's like a can of worms, okay? It's contracting and relaxing very quickly. To fibrillate. That's what it means. So if you're looking at a QRS complex, what you will tend to see is you'll see a lot of P waves. You'll still see the QRS waves, because the ventricles are still contracting. They don't contract for every single P wave, but they contract for every 10th, every 20th, every whatever. Do you see? That's atrial fibrillation. With ventricular fibrillation, you will not see a nice QRS complex. With VFib, what you're going to see is that. That's VFib. Just essentially almost just a one squiggly line. That's ventricular fibrillation. All right? Now, I was asked another question also, and that's to tell the difference between atrial flutter. Okay, so what's atrial flutter versus atrial fib? Well, atrial flutter has that sawtooth look, okay? Here, again, it's a sawtoothy kind of a look. You've still got nice QRS complexes, but your P waves are bigger than with AFib. With AFib, there are some times where you may not see the little squiggly line before you see the QRS complex, okay? But if you see a QRS complex, you know it can't be VFib. You know it's got to be atrial. All right? Prostate cancer is the second leading cause of cancer deaths in males over 55 years of age. So, is that a wake-up call for y'all? Hope so. Signs and symptoms and assessments pretty close to that for BPH. Okay, and remember what BPH stood for? Benign prostatic hypertrophy. So, what do we do, and how do we find out if this person has prostate cancer versus BPH? Because if we're saying that the signs and symptoms are the same, then we need to have some form of tool where we can differentiate between prostatic cancer and benign prostatic hypertrophy. Well, it's a very good test that's out there. It's called the PSA, which is the prostatic surface antigen. And what you'll find when you draw, it's a blood test, when you draw that blood test, you draw the blood, you'll find an increase in the alkaline phosphatase. Now, there's a question that NCLEX loves to throw out, and that question is, your patient is going for a DRE, which is the digital rectal exam, okay, and also is going for a PSA level. So which one should you do first? Well, the answer is you draw the blood level first, and then you do the digital rectal exam. And the reason is because the theory is that if you do the digital rectal exam first, you can hyperstimulate the prostate to produce more prostatic surface antigen, and you may get a false reading. So that's the NCLEX question. You do the PSA first, and then you do your DRE. Okay? So now we got treatment. You have prostatic cancer, and the treatment for it, and really pretty much the only treatment, though, is surgery. So they'll do a perineal prostatectomy, and essentially what that is they incise at the perineum, they go in and they remove the entire prostate. The complication and the problem with this one is that you may have, it's a possibility that the man may become impotent. And I tell this story a lot. I had a friend whom I treated for over 12 years down in Florida. I met him and his wife when, I met him and not his wife because his wife was already dead, but I met him when I first moved down to Florida, and he was 78 at the time. At the ripe old age of 88, he was diagnosed with prostatic cancer. And so we told him, you have several choices, but the best choice, we caught it early enough, the best choice is just go ahead and remove the prostate. And he said no, he didn't want to do it. And we said, why? He says, because I won't be able to have sex. He's 88 years old. So now I knew his wife was dead. Okay, so I said, okay, well, when was the last time you had sex? And he says, 25 years ago, when his wife died. So I said, no, okay, wait a minute. Now, I just really don't understand this. You don't want to have this thing because you possibly may not be able to have sex, but you haven't had sex in 25 years. But if you have this surgery, it might save your life, and if you don't have the surgery, you'll die. I said, you do like playing tennis, don't you? 88 years old, played tennis every single day. Amazing guy. Well, bottom line is he ended up having the surgery. I never asked him if he became impotent or not. It's like too much information here, okay? I figured if he had a problem, he'd let me know. And he had the surgery, and he's now 94. Yeah, and he's doing very, very well. Still playing tennis. He says a little bit slower. He says he can't return the aces anymore, but he can still he can still play tennis. So there is life after prostate cancer. I mean, that's something that you need to remember this completely. Okay. Bladder cancer is the most common site of cancer of the urinary tract. Now, some of the risk factors of bladder cancer include frequent UTIs. Okay, so that's why I said yesterday, I emphasized so strongly that if you do have to go, you have to go. Now, I know I give you all breaks, every so often you take these 15-minute breaks. But there are a lot of you in this room, and I know that the water level in New York City just drops drastically when you all go to the bathroom all at one time. Right? We have no pressure in the hotel at all. But if you've got to go in the middle of my lecture, go. Please go. Okay? I'm not stopping you, and I won't think it's rude. I'd rather you do that. So if you got to go, you got to go. Do not hold it, please, because you may give yourself a UTI, and then if you give yourself a UTI, you might get bladder cancer down the road. Okay? Some of the most predisposing factors of bladder cancer, as I said, chronic bladder infection and smoking. So if you're smoking, I hope there's no one in this room that's smoking. I really hope so. I mean, I had a group of students one time, and they asked me about smoke breaks. And I said, okay, let me put it to you this way. Our clinical rotation was on the 5th floor of this hospital. And I said, okay, let me put it this way. You can have a smoke break on these conditions. We are on the 5th floor. You cannot leave the 5th floor. But you can hang out the window of the 5th floor, okay, and blow downwind, and then you can smoke. But you got to